to 16 December 23, and the venue will be New Delhi. Coming back to the topic of discussion, today we are dealing with the finances in healthcare in India. It is very important topic as it always has the objective of equity in healthcare access. It is very important in terms of making policy decisions, decision making, and provision of healthcare quality services. In India, the most of the healthcare finances are coming from the out-of-pocket payment. For those who are not understanding OOPs, it is basically a household who are not covered under healthcare schemes or not covered under any healthcare insurance schemes. They pay from their pocket directly. So there is always a chance of a vicious cycle of debt trap. And if we get back the statistics, it was revealed like in 2023, in 2012 and 13, the OOP in healthcare finances was 68%. In 2019-20, it declines to 47%. However, there is some improvement in terms of figures, but the WHO financing, healthcare financing report suggests in 2017, the world over average of OOP is merely 18.2%. So India is still lagging behind. And there is a good scope as a hospital administrator and healthcare managers that we can think of how the healthcare finances can be streamlined so that the most of the population of the nation can be served. For more in depth and dwell into the details of the healthcare financing, we have the esteemed speaker, Dr. Ashish Gupta. Dr. Ashish Gupta is a renowned surgeon. He has reputation being NABH and NQS assessor. He is also the internal auditor for NABL. As the program director of AHA, Dr. Ashish Gupta has conceptualized, developed, and organized many new programs in hospital and quality management, also providing quality consultancy and training services in many hospitals. We also blessed to have presence of our visionary hospital administrator, President AHA, Dr. Yashpal Sharma sir. I would like to invite Dr. Yashpal Sharma for opening remarks. Sir, please.
Sumit, I think I cannot find his name in the list.
Right, sir. So, sir, we can directly coming to the topic of discussion. I would like to ask Dr. Ashish Gupta, sir. Sir, dice is all yours. Please proceed, sir.
Okay. Okay. Thank you, Sumit. Thank you for everybody to having joined this webinar. So, as Dr. Sumit briefed you about the topic, financing healthcare is a very critical issue, especially for a large country like India, having a population of about 1.4 billion. And let's go through this rapidly, and then we'll have a couple of time to discuss the issues which will come up after this. Now, since healthcare is a very public good or a social good, we can't leave it just to vagaries of the market. We have to do something so that a large population of India can have equitable access in healthcare. Now, to have equity, it is very important that we finance it in such a way that the poorest of the poor in the most remote area can have an access. So there's going to be three issues which we are going to take up. One, how we should finance the healthcare, number one. What model of healthcare provisioning should we have in our country so the accessibility of healthcare is equitable? And more importantly, how we can serve such a big population and what type of models we can have at our place for delivering the healthcare, keeping in the peculiar behavior, health-seeking behavior of the people. That has to be looked into. There's a particular health-seeking behavior of the people as well, which affects the accessibility to the healthcare. Now, at present, the public resource means the government funding committed to healthcare budget in India is about 40% of the total health expenditure. Rest comes from other sources. And in India, a large scale people who are in poverty line normally finance their healthcare from out-of-pocket payment, which is also known as OOPS or out-of-pocket expenditure or OPE. Uh, and this leads to a big inequality in the way the people access the healthcare. Now there's a paradox. People who have capacity to buy, means have money, they get healthcare without paying directly for healthcare because they have got big private insurances with them. And those who are suffering from hand to mouth existence and don't have any type of insurance, they make direct payments. And usually with a heavy burden of debt to access the healthcare market in this country. Let's see some transition of the hospital-based care in India, the financing of part of it of the last 100 years. From the pre-colonial times to colonial period to the post-independent period up to mid-70s, I will say. The state means the government and its agencies were the main providers of the services as well as the main financer of the services. Means services being provided by the public hospitals, right? They are talking of hospital care. And in addition to that, there were charitable hospitals organized by many big business houses as well as charitable bodies, which were also non-state players but providing healthcare. But from mid-70s, the first change came into the medical education. The major transition was that post-graduation graduate studies started picking up. People started preferring post-graduate studies. So this led to specialization and super specialization, and which become the main characteristics of the medical care in this country. On one hand, the specialists started, opening private nursing homes to apply their skill and knowledge on the public. And on the other hand, the corporate sector also started showing interest to enter the hospital sector. That was the transition happening in mid-70s. And then, coupled with the major change in the medical technology, we rapidly went on to have commodification of healthcare. Now, healthcare is a commodity. People want to buy more and more of health. So it also became a for-profit hospital became a lucrative proposition for everybody. By 1980s, the state was already accelerating the investment in the hospital. Means government was not putting much money, and privatization of the healthcare took over. And by the turn of the millennium, for-profit hospital sector had not only become dominant but became the order of the day. Even the state sector, means the government, also started using the private sector with user charges like empanelments and all, not providing services but sending them to the private hospital to get services or contracting out services. So this was started happening. But this is what we are talking about. The largest source of financing of healthcare in India is out of pocket, self-financing expenditure. That is my concern here today. Now let's look at the out of pocket. What we call as out of pocket expenditure is that money which is paid directly by the household at the point of receiving the healthcare. That is the money paid directly to the healthcare provider. And this occurs when the services are either not free of cost available to them, means some government hospital is not there, or they are not covered under any form of social or private insurance. So they have to pay from their pocket. So this is reference from WHO Financing Profile 2017. It's written there that out-of-pocket spends make around 67.78%. That is 212.13 data. After that, we have improved on that of the total health expenditure. Now I'm going to use these terminology repeatedly. Total health expenditure is that part of expenditure which is both public and private money coming to the healthcare as expenditure total. So when I say total health expenditure, means all money which is coming, whether through insurances, whether through the out of pocket or from the government money, or even from aid which is coming. But it has decreased after that, and still in 2019-20, it is still around 47%. World average of OOPS is 18.2. So that is the disparity we are talking about. OOPS as healthcare mode of financing is very regressive and iniquitous, which means it is rather harsh on the people because the poorer household who are at the bottom three quintiles of the population or are either below the poverty line or they are at the threshold of the substance. When the illness strikes such household, they desperate. They have nothing to go ahead with. Furthermore, the burden is largely self-financed by the household. Normally, it does not come from their current income. It comes either from a debt, means they take some money on loan, on interest from somebody, or they sell something. That is sale of their assets. That is very harsh on them. And coupled with this, if we consider that those who are ill may not seek health care, means the burden of illness is going to increase and uh, ill health will be there in the community, and sometimes majority of them are threatened with their only chance of survival. So this is the problem we are talking about. So keeping that in the background, we should now start thinking about the healthcare being financed in some countries, and then we'll go in our own country. So look at some other countries. In those countries where there is a universal access to healthcare or healthcare provision is equitable, the financing mechanism is normally a single payer system, means it comes from tax revenues paid by the government, or it comes from some social or national insurance. And it is normally, this fund is administered by the autonomous health authority, means the public money coming from taxes, the social insurance or national insurance money coming to a single pool. And then it is administered by an autonomous agency which is mandated under law. And then the service provision is either by a government hospital or a private setup. That is the different issue because the payer is common and they keep on paying to the public sector as well as private sector, whosoever provides services. Good models are in Canada, Sweden, UK, Germany, Costa Rica, South America, Korea, Australia, and Japan. We'll take these models as we go ahead. But experience from these countries suggests that the key factor for establishing equity in access to healthcare is proportion of public finance in the total health expenditure which comes to the system. That is almost around 80% in most of these countries. Means 80% fund is coming from a single payer, that is the government, and is collected in some other form. We will look at that. In contrast, the public finance only accounted for about 17% in a WHO report 2004. It has improved after that of the total expenditure. That is why in India we got a poor equity record for access to healthcare and health outcomes in comparison to the most countries like China, Malaysia, Sri Lanka. At that, I'm talking about 2004 report, where at that point of time it was 30 to 60%. It means public fund was 30 to 60%. India 17%. With this background, if we want to move towards developing a robust healthcare financing and delivery system, we should incorporate the learnings from the various other healthcare systems. But simultaneously, we can't copy paste a system in this country. We have to look at the peculiarities of healthcare needs and health seeking behavior of our own citizens. Now, these are the changing trends in financing in India. From 2018-19, India's total health expenditure was 5,96,440 crores, which is around 3.2% of the GDP of the country. This figure you have to remember. 3.2% of the GDP in 18-19, total health expenditure. Means both public and private. In the total health expenditure, now this PT of 5,96,000 money, between 2014 and 2020, the government healthcare expenditure was only in 2014 29% of this money, and now it has become around 41%. Means the government participation in this money has now improved in 6 years between this period. And another flavor you have to understand here, that in the total health expenditure which is happening in this country, in 2014-15, it was around 51.3% money was coming to the primary healthcare, means preventive, promotive, primary healthcare. Now it has increased by around 4%, 5% to around 56% in 1920. Means in 5 years, the amount of money in the total health expenditure, which is going to primary healthcare, has increased up to 56%. Means government is still focusing on provision of the primary healthcare at the basic level to decrease the disease burden, not to the tertiary and secondary care. Now, with this 3.2% of GDP coming to healthcare in 1819, we can contrast it with the US, who is spending 16.6% of GDP in 2022. So we are lagging in that component here. Now, this graph will explain a lot of things to you. Let's look at it. Now you can see two color lines, one orange line and one blue line. Let's look at the orange line first. Orange graph on the x-axis we are showing the year, and on the y we are showing the percentage. So let's see, which is the out-of-pocket expenditure, which is shown by orange line. In 14-15, 62.6% oops coming to the healthcare, means people are spending from their pocket. 15-16 direct money, means paying directly for taking healthcare. It doesn't include the insurance money paid to insurance company as premium. And then coming to 16-17, it is 58.7% and sharply declining between 1 year to about by 10%. It is when a lot of development was happening regarding start of the National Health Authority and all. It sharply decreased to 49%. Now it is around in 1920. We have got data till 1920, which is authenticated 47.1. I have got data for the next year also, which I show you just now. 47.1 in 1920, we have got the out of pocket. So decreased from 62.6% to 47.1% over a period. And if we see the blue line here, which is the government health expenditure, but government is spending out of the total kitty spent on the healthcare, that is 5,96,000 money I'm talking about per year. We were having 29% government health percent of the expenditure coming from the public, means government health, government share, which gradually increased and suddenly increased in that 1 year when National Authority was gone about 10%, 8%, and now it is 41.4% in 1920. It increased by 1% further, and out-of-pocket expenses have almost decreased by 0.5% after that. So this is what we are looking at. Means gradually we are decreasing the out-of-pocket expenditure and increasing the government percentage in this spend. Now, this is for the next year I'm showing you. This is what our Honorary Union Finance Minister Nirmala Sitharaman put on 31st January 2023 in the Parliament. They said central and state government's budgeted expenditure on healthcare sector in India reached 2.1% of our GDP, means the government part I'm talking about in FY23. While it in FY22 it was 2.2%, decreased by 1% against 1.6% in 2021. Means from 1.6% of the GDP being spent by the government, these are government expenditure on healthcare, it has come to 2.1%. So this is the Economic Survey 2023 report. Now this we have to focus here for some time. There is a paradox here. We have to understand what I'm showing here. Let's look at these years from 2013, 14 to 18, 19. Let's look at the second column only first for the time being, where I'm showing you the percentage of fund GDP dedicated to healthcare, total, private and other sources, public. 4%, it was 4% of GDP in 13-14, gradually decreased over time till 18-19, 3.2%. Means the total percentage of GDP expenditure, total government plus private expenditure has, as a percent of GDP, has decreased over time. It is decreased. Let's see the government health expenditure as percentage of the total health expenditure, means the total kitty of 5,92,000 crores. How much money percentage of that money comes from the government. It came around 28.6% in 13-14 and increased gradually to 40.6, now 41.7, I told. So it is increasing. It is increasing gradually. That's a good sign. And out-of-pocket expenditure, which was 64.2% in 13-14, has gradually gone down to 48.2%, now 47.7%, 19-20. It has come down. But the last column is very worrisome. Here, what I have done is I have put the per capita healthcare expenditure at constant price of 2011-12. So indexing 2011-12 means the buying power of the money has been converted to a single point, so we can understand what is the real increase in the per capita expenditure. That is at constant price of 2011 and 12. I have calculated. So per capita constant price is in 2013-14 was 3,174. It has hardly increased. Even 18-19, it is 3,314. And in fact, it has increased from 17, decreased from 17-18. Maximum was in 16-17. So once we adjust the per capita spending on healthcare with a constant price index of 2011-12, we come to this figure, which is now worrisome. This means there is hardly any increase in the allocation per capita healthcare spends in this country. And this we have to look at it. The total expenditure has declined as a percent of GDP. The total government health expenditure as percentage of total health expenditure has increased over time. OOPs have decreased over time. And per capita spend on the health in this country has remained static. It has not changed much over the last 8-9 years. So this is the latest figure of 1920. Now we have got this much, 3,516 per capita, which is almost 202 rupees more than the previous one. That is what we are looking at. Now, here we have to look for some more time. This is the source of funding of healthcare from different economies. Now, look at that very carefully. The red part, these are the countries given below. The red part, this is a split bar, vertical bar is there. Thus, there are 4 splits in this bar. Majority have only 3. The red one is the government expenditure. The orange one on the top is the OOPs, and the middle bar is showing how much is a prepaid expense, means how much money is coming from private insurance in the sector. In India, we got a small red bar also, which shows what is the aid we are getting for healthcare from different sources. So four parameters are there, but majority are showing only 3 parameters. Let's look at the first group here with the high government spend. Let's look at the first group here with the high government spend. We can see that most of these have got tall red bars. Means the government spend ranges from as high from around 70% to 88%. These are the countries where the healthcare is good, and the out-of-pocket expenditure ranges from 5% to 24%. 24% in Spain and 5% in Netherlands. And if we look at Canada here, 14% comes from the out-of-pocket, and around 72% comes from the government, and rest comes from the private insurances. So this is what we are looking at. If you look at the second group here, the second group is a group where there is a high government expenditure and plus out-of-pocket expenditure is also there. Here we can see that in Singapore, 42% coming from government and 56% coming from out-of-pocket. And we can see in Ireland, around 18% coming from out-of-pocket and 68% coming from the government spends. The average, the world average of healthcare provision funding is coming as 58% coming from the governments, 30% coming from out-of-pocket, and rest coming from the insurances. So this is the word that the second bar from the right side is showing the world average, which is there. And on the extreme right, I'm showing an Indian bar, but there's a slight change here. Now, this is a slightly 2-year-old bar, 31%. Now, it's not 31%, it is 41.4% till last report. And oops have increased to 47.1. So, our bar is slightly better and it is uh, improved after that. But world average is almost this much. So, keep remembering the world average is 60% fund coming from the government, 30% out of pocket, and rest coming from the insurance companies. So this is what we are looking at. This is the funding we are looking at. Now coming that now there are, as I say in the beginning, that there are three issues we are looking at. If India has to improve its healthcare outcomes and have to increase the equity in access, we have to increase the role of public health expenditure. One take home message. Now we also have to organize our services in a way, because we have got a large geographical spread of our population in the remote areas as well, with different social cultural behaviors. So we have to look at the healthcare delivery can be adapted to this country to provide the needs of these people. And India has its peculiarities as well, and we cannot simply transplant somebody's healthcare system in this country. We have to look at our own system. Uh, Universal health coverage is a very big issue. With less than 4% GDP, very, very critical how to give access. Let's look at the word order of the healthcare coverage, uh, how much we can see. So this graph will show you one thing. So I tell you what this how to look at this graph. On the y-axis here, we can see the universal health coverage. It means what percentage of people are receiving healthcare uh, directly from the government system. And on the bottom line is the funding, how much money is coming into in US dollars coming in this. And this dotted line, which is going from below, from the left side to right side up, shows that at particular amount of funding, how much people access the healthcare has been shown. We have minimum this much people must be having access to healthcare. You can see India here. I've marked India. This dot is at this much level of spending of healthcare. We are not even meeting this line, which shows us that we should be at least having a coverage of this much population, means around 70% of population with this much fund, we should have a coverage of the healthcare. That is why these people start seeking healthcare from quacks, from local practitioners, and normally spend money out of their pocket. We have to look at that accessibility part also. Funding we can do, because on the extreme right you will see United States of America, Norway, Switzerland, UK, which are having almost 90% healthcare, or above 90% access of healthcare to people, but at a huge cost. This cost we cannot afford. 16% of GDP is the cost they are spending on it. At a small cost, how we can, because look at some models of Bhutan, Uzbekistan, even Sri Lanka. They are with almost same percentage of fund coming to them. We have to look at their healthcare delivery system from especially these countries, because their healthcare seeking behavior is almost identical to the Indian population as well. And they are showing a better accessibility and are shown better on the universal health coverage tracer, because we cannot be below this dotted line, because below this dotted line, you see Pakistan is on our left side, down Mauritius, Nigeria. We are going to go in that category. So this is the tracer gap for the current level of healthcare spend for the country, means accessibility is an issue in this country. And when we start talking about funding healthcare, thinking of some healthcare models, we should not only think of money, we should also think of the systems we're going to put in this country. So the more people get accessibility to healthcare with the same amount of fund, means bringing efficiency to the system we are talking about. Let's uh, see another aspect of it. We'll just put that thought process behind us. Let's look at another thought process, then we combine them together. Now, what role a government can play in healthcare sector? Government can play three roles. Government can be a regulator. Government can be a payer. It can make payment, or Government can be service provider. So three roles government can play in healthcare. So let's look at this model. What mix of these flavors should be there in the government to deliver a universal health in this country? Let's see. Let's see some models. So let's see this uh, uh, classical healthcare system. I will take some time to tell you what is there. A lot of information, but majorly you have to see on the extreme left. I have seen what are the model, what are the components of the model. Let's look at Bismarck. Bismarck model is basically a model where the people buy a private insurance, and the services are either provided by the uh, private players most of the time, and the government has got a role of getting regulation only. Well, government is a regulator. So classic Bismarck model is a private insurance model. Payer is a private insurance. Financing is done by the citizen directly. They pay, or employer premium is there, or the citizen premium is there, comes from their incomes. Providers, healthcare providers are mostly private hospitals. Government has got a role of regulation only. They regulate the practice, ethics and all. Price control, government can do a bit of price control, but not majorly can affect the prices. Model is successfully running in Germany, Austria, US is a mixed model. In India, this model is being followed by the private insurance company, which are around 10 to 11% of funding coming from them. That is what I'm talking about. So new classic Bismarck model is a mix of public and private insurance. Both types of insurances are there, not only private. Again, the premium is paid directly by the public only. It doesn't come from the government. Rest model remains same, and this comes in Netherlands and Switzerland. And PSUs normally follow this model in this country, PS, public sector undertakings. So the Bismarck model is basically an insurance-based model where the premium is paid by either the employer or by the person himself. Beverage model. Beverage model is a model, broadly speaking, where the government collects taxes and is the payer for the healthcare provision. How it collects taxes is a question which has to be addressed. So it can be a different type of tax collection, direct, indirect tax collection. But beverage model is basically concerned with the government paying as a payer and collection coming from the taxes, citizen taxes. So this is the second model I'm talking about. Beverage classic model is basically the financing is by the taxes. Provider, classic provider is the public sector hospital, and neoclassic is private. So that is the difference between two of them. The models may be different. The hospitals are owned by the government in the classic. In the neoclassic, the hospitals are owned by the private sector, but the money comes from the government as in some form. And the government has got a role in classic model, both for paying, because it comes from taxes, government pays, and also provision of the services. And in new classic, because the services are providing by the private hospitals, government pays. It does not provide the delivery. So where the government pays and government delivers is Britain, NHS model, Cuba, Spain. In this country, the state-run hospitals, medical college hospitals, private government hospitals, district hospitals are run on this model. In this country, where the government pays but does not deliver the services, is a CGHS, ECHS model, where the government is paying for the services, contracting out, and we are getting services from the private sector. Some part is being utilized there. Why I'm referring to these models here is so it becomes easier for anybody to understand what this model is. Now, this is a Douglas model. Douglas model is a model where the government runs an insurance. Government run insurance is there. No, it's not a private insurance. Citizen pay premium. It is subsidized premium, but citizen pay premium to a government run insurance. Services are taken mostly from the private sector. Government does not spend money on creating hospital, healthcare infrastructure, but government has got regulation because government is running the insurance company. Government can have a strict control on prices because government is deciding everything. So we can say how much money to pay for an appendix or a gallbladder or a cesarean has to be decided by the government. You want to take it, take it. If you, as a provider, if you don't, just leave it. So this is the type of attitude the government will have. This is Douglas model is followed in Canada, Taiwan, South Korea. People either have group insurances or individual insurances, but premium paid to the government, citizen premium coming to the government. And this is the model. And last model which we follow in India in 50% of cases is out of pocket. Citizens are there who are the payers. Since citizens themselves are financing directly when they access healthcare, they don't have to pay otherwise if they don't go to a healthcare provider. And provider is both public and private. Regulation and delivery is the part of the government. Government can regulate some laws, do these, don't do this. But government has got very limited control on the prices. You have a clinic, start charging some amount of money, government cannot limit your payments. So this is the model we followed in this country. Most of the developing countries are having this model only. The dominant model, up to 50% of the healthcare seekers are following this model. So this is basically to revise Bismarck is where the private insurance companies are there, citizen pay premium. Beverage is where the government collects taxes and is a payer and the provider both, or a payer only where the private sector is providing the services. Douglas model is a government-run insurance, premium paid by the citizens but subsidized, and the services are mostly private. So this is what I'm talking about. Let's go a step further with this knowledge. Now, we were coming back to the financing part with this background knowledge. As I told you, that 47% is oops now. 47.2% is oops now, means out of pocket. The gray area is showing you the part. We want to decrease this gray area. Basically, this gray area is a troubling part of finance. Is not, that is the major stumbling block which blocks the accessibility, which increases the disease burden, which pushes people below poverty line. This is not a good model. So 47%, that gray area on the right side, we want to decrease. And 41% is now coming from government spending. Tax it has increased from 17% to 41% over the last 18 years. That is a good thing. But this 12% is what, 11.7% precisely, is what is coming from the private insurance companies, people paying their premium directly to them and seeking healthcare. Now, the only way we can decrease this gray area is by either expanding this 41%, means yellow area of the public spending, or increasing the 12%, this orange area of the insurance sector. That is how. So let's look at one model. This is one way we can do this. We can gradually increase the government spending to 70%, simultaneously increasing the private insurance sector, encouraging private sector insurance also to insure people with the direct payment being done by the people to the insurance company and seeking healthcare as per their requirement, and shrinking moves to 10 to 15% only. So only then accessibility, a universal accessibility index of this health-seeking behavior will improve in this country. How to do it? With that background knowledge, if we go back, let's go to this place again. Let's look at this. Now, with this knowledge that we want to do this here to that bar, means 70% will come from the government, 20% around comes from insurance, and 10% comes from out of pocket. Let's look what options we have here. These are the only healthcare financing models we are looking at. We want to decrease the extreme right one. So what we suggest is because the private insurance model, as I told you, is the Bismarck model, private insurance. We want to increase to double what we have now. Let's double the private insurance. So we have to look here. We have to look here, basically private insurance companies, where the services are provided by the private hospitals to them. Citizens are paying their premium directly. We encourage this sector, and individual and group insurances we try to stimulate in this country. Then I said we increase the public spending. The public spending is in two models, Douglas model as well as beverage. Douglas is a government-run insurance. We have already a government-run insurance running here, government funding, which is PMJY. We have got a beverage model where the government puts money in its own hospitals, means own infrastructure. I said in the classical model of beverage, the government is the service provider also. To put some money in the, but where to put, whether to put in tertiary or primary care, we'll talk later. But first of all, we should be ready to put money in a healthcare infrastructure in this country to develop. And we should also try to encourage the private players to increase their bed strength and create economies of scale in their hospitals so that the services can become cheaper at the purchase rate. You know, their price can come down. We can look at that beverage model. So stimulate this part also. And then coming the Douglas model where the government run insurance is currently being given to the BPL patients, 0.5 billion people of this country getting 5 lakh uh, health coverage a year. So we should try to increase the scope of this insurance to other sector of the community as well, with a higher income in the middle income group as well. But we must move our 50% clients from the extreme right out of pocket category to some to Bismarck, mostly to beverage, and some to Douglas model. So we can look at that. Uh, but when we are doing this, we should also look at these issues because these are the, when I say disruptive trends, they are not disruptive in a way in a negative connotation. Means it disrupts the current thought process because we have to start thinking differently because these factors have to be incorporated when we start thinking of the models for providing. So what is the disruptive trend in the current Indian health economy? First of all, is the epidemiological transition to the disease burden. We are going to NCTs from the communicable diseases gradually. Aging population, increasing life expectancy, non-communicable disease burden is gradually increasing. We should look at that. Rising patient consumerism, people want to buy more health. Commodification of healthcare has happened. People are increasingly becoming aware of self-care. We should utilize this behavior to bring out low care model and preventive promotive model. People are aware of self-care, so we can go to preventive promotive sector and catch that opportunity. People have easy access to information and technology, and immediately they come to know where they can compare the prices, they compare the timeline and the results, and can seek healthcare. Now, expansion of continuum of care. In this country, as I told you also, the government spending, percentage government spending, the total health spending has increased to 56% from 51% in 5 years. Means focus to primary care, promoting preventive care, pre and post hospitalization care has improved, and this is providing care outside the hospital wall. You understand the cost of providing care in a hospital is high. If you start providing care outside the hospital boundary wall, the care is going to be less, the cost is going to be less. So continuum of care must be expanded. Now, shift towards quality-based care is already there with NABH, NQAS, and NABL and other quality standards already there. You all aware, do the right the things time always, and first time always, and then uh, no redoing. The time taken for cure is less average length of stay, better cure rates, better morbidity, mortality statistic data. I think quality is the buzzword there. Increasing patient participation. It's very important that people are participating, try to understand the healthcare behavior and use of technology like digital revolution to deliver healthcare. We can make healthcare accessible to in hard to reach areas, in untapped geographical areas, and increasing penetration of insurance. The effect is now that we have to rethink of the healthcare delivery models, and we should be talking about the models based on digital technologies which are asset light, means they don't have big type of assets, fixed assets with them. They're innovative business models and they should be moving closer to the people who need services. Okay. Of course, with the National Health Protection Scheme coming up, another opportunity is there. We are going to open up the new health economy. To summarize, I would say India is a microcosm of all healthcare system, whether it is beverage or other systems or Douglas system. We are very fast evolving healthcare system. You have seen in the last 15 years, after NQAS was born, especially, the public health has been revolutionized. It is evolved like anything. And the basic thing that we are trying to develop health wellness centers at the most peripheral part of the country, and utilizing the services of community health officers there means the direct burden on primary health center has also decreased. So our doctors can think about complicated problems and they can be utilized for those problems for which they are actually trained. So so this is a very good move coming to us. But a challenge is there that less than 4% of GDP coming to healthcare with a actually world average of 10% is basically a very worrisome part, and out-of-pocket expenditure of 50% is another worrisome part. We should normally have to have a high spending, government spending, and these are the other positive things happening to health economy: NABA, JCI, NQAS, accredited labs, and most importantly, the cost of treatment in this country is about 1/10 of US. That is what we are actually able to achieve. Very good. And we have got a big scope of alternative system of medicine, rejuvenation therapies, wellness programs in other systems. We have got like yoga and all. We have got a big kitty of these interventions also, which can be a part we can think of. Now, what needs to be done is the government should allocate more funds to healthcare, number one. The total GDP allocated to healthcare from both private and public sector, total expenditure should increase. We should focus on universal health coverage because we have seen in that graph, we are not reaching that dotted line with the current volume of expenditure we should try to achieve. We should try to contract from the private hospitals, healthcare providers, the service at appropriate terms to control quality. There has to be a robust quality accreditation system and a regulatory system for providing healthcare, so nobody can misutilize the system. Stakeholders must be trained and must become a part of this restructuring process. It should not be taken into isolation. And we should rope in the private healthcare providers and associations also when making this. Now, coming to the last two slides, I'm finishing. Ayushman Bharat PMJY scheme is a tectonic shift. It has basically made the difference. This is the world's largest non-contributory government-sponsored healthcare insurance, 0.5 billion, 1/5 of the Indian population. And especially I was talking about that population which was depending on OOPS for their healthcare service provision. That is where we have hit with this scheme. That is the exact place we have hit with this scheme. Additional, the source of funding has come from 1% cess on the income tax. That is slightly worrisome because those who pay taxes complain that our money goes to social cause, and in this country that taxpayers base is very narrow, so it comes from a narrow base. New institutional structures like National Health Agency and state health agencies have been made in this country, and 5 lakh family floater cap, and premium is goal 60-40% center stake. Most vulnerable with OOPS, this is the population and we were talking about, and both private and public hospitals are providing services. So a paradigm shift towards new economy there. We should have output-based strategic purchasing of healthcare from the private sector. We can fix prices, we can fix packages, and we can say this is the output, so this is what we pay for it. We can merge many government schemes together and come out with one insurance scheme only. And government must shift from provider to payer also. We cannot say we are simply provider payer, because government payer, if we increase to 60 to 7%, that gray area will decrease. We are for sure moving towards the budget hospitals. This is what we are moving towards gradually. Thank you very much. I think, Sumit, you can open the webinar for discussion if you want.
Thank you, sir. Sir, it is very informative, sir, and it is very much streamlined in terms. It took a journey from where we were and where we are, and what is the prospects that we can see into the healthcare financing. Coming to the point, sir, you have very well articulated with the OOPs and the current and the present as well as the future can India can do. And you have correctly pointed out, sir, our position in the world forum where we are still have to work a lot. I think now the session for questions has been open. Please raise your hand, and once the person who is asking, please introduce yourself in brief and ask the question, please.
Hello.
Doctor, yeah, please.
Hello, Dr. Gupta. Good evening.
Good evening.
Basically, I'm Dr. Anindra Chatterjee, a life member of AHA.
Hello, how are you?
Fine, fine. My question, it is an extremely well collated data, I must say, and congratulate you. But my very specific question is that with Ayushman Bharat coming in a big way, you know, the government is trying to cover up to 1 billion Indian population in a phased manner. Uh, is this a methodology of reducing government spending as a percentage of GDP, where the government had to spend directly on the healthcare in terms of government hospitals, primary healthcare, and etc. Do you think by passing on the responsibility with a 5 lakh floater on each family, the government is able to reduce further its expenditure on healthcare as a percentage of the GDP?
No, I think that is what I was getting at. We are not looking at the per capita spending. Per capita spending, I told you at the static purchase level of 2011, well is same. 3,300 is what we are spending per capita healthcare spend in this country. We have to increase this per capita spending. That is, you are rightly hitting that part. But until we increase the per capita spending in any way, whether it is from private or public spending, but the total GDP, we have to go above 4% very shortly, because otherwise the resources will be deficient in the system to serve those people who are insured.
But what is happening is across India, I have roamed and interacted with various hospital administrators with Ayushman Bharat, or let's say certain state government schemes where we are having this kind of policy. People are shunning their own individual insurance, individual insurances. Like I know a huge lot of people in Calcutta who are having the, our state insurance scheme, which was parallel to the Ayushman Bharat, and they have sacrificed their own individual premiums and individual and unfortunately these cards are also not being accepted by many of the hospitals. Now these people are in doldrums.
Okay, Ananda, I will just cut it short. I will tell you that is what the political application of a scheme is. It was basically meant for below poverty line 0.5 billion individuals. Now many states like Rajasthan and West Bengal have opened this scheme to everybody. So this is the major problem in the system, because the planners behind it should not be politically motivated to extend the scheme to that area for which, because I told you this scheme was meant only for those people who were
Below the
around
poverty line.
at the threshold of sustenance and are in the OOS category about 50%. That was what it was meant to. That's why I say the mix of these models is very important. Bismarck, Beveridge, Douglas, and OOS. Because instead of migrating them to the Douglas model, they should have migrated them to the Beveridge model. Beveridge model was basically provisioning healthcare facilities and utilizing that money in strengthening the healthcare system, rather than only providing the money as the income as healthcare pure to the private sector. And especially with a small amount of money coming to the healthcare system, we are not affecting the GDP in any way or the average spend, which is again is 3,300 only.
Yeah.
Dr. Ashish, good
Sir,
afternoon.
Good afternoon, Dr.
I'm,
Param.
Dr. Paramas,
yeah,
Dr.
good
Paramas,
afternoon. I must compliment you for a wonderful presentation. But most of us being a private healthcare providers or administrators, I would like to know what is your take on, you see, the low packages of Ayushman Bharat or other health schemes, because of which many private hospitals are either shunning away or turning away the patients. How to increase the revenue and acceptability by private hospitals, from the patients? Some model like in UAE, where the employer has to provide insurance to all the employees. If something like that can be incorporated or made essential in India, I think people will get better quality healthcare at a better price, where hospitals will also be happy to serve people. So what is your say on that?
Yes. Again, the basic fault lies with applying a model to a population for which it was not meant. As Aninda also told you that people are shunning their insurances, private insurances, because people are moving from the Bismarck model to the Douglas model, because that migration has been permitted. But we have to compartmentalize these systems, because you have to fix up something like the income tax return or the annual earning of a person before offering a government insurance to them, where the premiums are very low and the payouts to the private healthcare industry is very low. Is because because there is these days there is a trend of free delivery of many things to the people for the vote bank. So our insurance has been offered, and there is a problem. So somebody must correct it there, that it is meant only, the migration to the Douglas model is meant only for those who are in use, not for everybody. So I said we have to enlarge the sector of the private insurance to 20 to 25% from existing 11%. It is this sector which is going to put the money in the private healthcare system's hand to strengthen and provide quality. I think there is a major policy decision to be taken at that end, that where not to provide this PMJY insurance, to whom not to provide.
Thank you.
Hello. I think Dr.
Yes.
Sangat Naik is next in queue. He can ask the question.
Hello. Good evening, sir.
Yep. Please go ahead.
Then,
Hello, sir. My question is there any data on various costing pattern of health expenditure, like segmental breakup of health cost, drugs, diagnostic, transportation of any countries like that? So we can target it and focus it on that segment only.
yes, there's a lot of data. I think I can show you some data right here itself. You can go to this document. I'm showing you this document here. This is a national profile 2022. This you can get from the net 17th issue. And this is the full 500-page document with complete data on, I can show you some part of it, what data we are talking about. You can access this data. This is detailed breakup data on, this is only this you can. In the socio-economic indicators and health financing indicators, and then it's detailed data is there, and it talks about what we are spending in what state and how much. This is the data.
Okay. Sir, is there any, as for your presentation, sir, you have shown different models. We can link these models with outcome of the patient.
Outcome of patient in all models will be okay, because it is only that the financing will be changing. Outcome will not be affected, because for outcome we have to look at some other issues. So the most important part is, because Param and Ninda was worried. I must tell you 2-3 things here. Until we start thinking healthcare differently, we in India, we will not be able to satisfy the healthcare needs of such a big population with the 3.2 or even 4% GDP spend on that. So the things I always say to people when we're looking at healthcare: decrease the stay of a patient in a hospital. So hospital care is the most costly care in the whole system. Then create a kind of the hospital care where the super specialty and specialty hospital or a single specialty hospital are serving more number of people, creating economies of scale and expertise to handle these patients faster and accurately. It's one thing. focus more on daycare surgeries, and even you can have hospital. If some service you are not, don't try to create that service. You have an occasional patient of cancer or heart coming to you. Don't try to create a patient. You can have a network hospitals with you. As a small hospital, a mid-sized hospital, you can have a part of hospitals where you can directly send your cases to get treated for those ailments. Don't start creating even the diagnostics. I see hospitals buying MRI, CT scan machines and then utilizing them to 20-30% efficiency only, and then coming out because number of clients in the people who remain same in the community. We try to take a piece of the same pie and make our pie larger and make some others pie smaller. That is should not be there. So start having some network with them. So this is what I always talk about, how you can bring down the cost.
Thank you.
Sir, I think Sulan Naski is having a question. Yeah, please, sir.
Yes, sir. Yes, sir. Thank you very much, Dr. Gupta, for very great presentation. Sir, I just wanted an opinion regarding when the
You should write the name, not.
Your background voice is there. Resume, Dr. Rao. Yes. Yes. Nazir.
Yeah, background noise.
yes, sir. Yes, sir. Am I audible, sir?
Nazir, go ahead.
Yes, sir.
You really ask.
So just want an opinion about, because whenever I think I'm an emergency, first of all, I'm a clinician. I'm working in a Narayana hospital, Jammu. But it's my personal question, which I think is about rural medicine. So what is the role of economically viable rural medicine, especially the private sector, if you want, they want to go into the rural parts like medicine? This is what I want to know, sir, personally. Yes.
You know, when we want to do cost containment strategies in health, as I told you, the government is also having a shift of its strategy of funding. 56% of its fund goes to the private primary basic rural care. It goes there. So I always call this, I call it differently. I don't call it rural care. I call it primary and pre-hospitalization care. It's a primary and pre-hospitalization care. People are not in the hospital. So when we are trying to do a primary and pre-hospitalization care, we should look at 3-4 things. One is to attract the private sector to the primary and pre-hospitalization care. We should try to encourage them to open primary care clinics and primary care specialty clinics also. Means the person with hypertension, diabetes will go to a primary care clinic in the periphery and look into it. You should also encourage retail pharmacies by the private setups online with Janaushadhi. There may be many private players in the market who can work on a larger scale. So as an economy of scale will come, they have 2,000, 3,000 pharmacies coming in the system, and they are there in the system. They can always. We can also rope in the private sector. Telehealth. Telehealth is one area where technology and investment needed. So one can there. And more importantly, the private sector can go to care coordination centers. They can be care coordination center. You are a tertiary care or a secondary care specialized hospital, and the people come from for the to discharge the people, or people are prepared, getting prepared for surgery. So pre-hospitalization and post-hospitalization care can be provided in the care coordination center of that hospital in that periphery, and care coordination center will also bring in money in the system. Also bring the healthcare close to the home of the patient, and accessibility will be better. And I tell you, people spend more money coming to a hospital. You open a free district hospital in the district level. Person is traveling 80 kilometers, 40 kilometers by bus, by public transport. He's spending more money on a transport, and more time is lost on that. So by opening care coordination clinics in the periphery, a private sector can. A lot of opportunities there.
Thank you very much, sir. This care coordinator is one of the things which I was not knowing, but I think it's a wonderful thing to have. Thank you very much.
Yeah.
Hello, Dr. Gupta ji. Hello.
Yes. 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 Go ahead.
I am Dr. J.N. Rao.
Hello,
and
Jobri. Hello.
professor in hospital administration from Hyderabad.
Okay.
Gupta, I saw 1 month is there for elections in Congress and BJP. He never mentioned in manifesto or agenda regarding this all insurances all. What is the problem? This is the problem, our problem or political party problem? Since 70 years, the ruling Congress and BJP, they never bothered to include hospital administration in the medical colleges, including NMC. MCA, they thought something, but NMC, they never bothered. Who's a mistake? Is the government or BJP government, Congress, or our administrators' mistake, or the finance fellows? Can I explain? Since 30, 40 years, I am talking about theory, but the practically is very, very, very poor. Because in rural villages, the most of the people are suffering to pay the private health insurances, and they're eating the money, corporate hospitals. What are your solutions, sir?
So solution is very complicated, but
Since
more
40 years, I'm
importantly,
learning all the lessons.
we,
Chart and
we are a group
account,
of
I attended all the things, sir. Can you give any
we are
guidelines
a
to
group of
government?
hospital.
Now the most powerful is Congress and BJP.
Can I
Can
pitch
you
in,
put
sir?
in the agenda and manifesto?
We are not talking about any political party here. It's a
Yeah,
academic
yeah.
forum, but
This
still
is
I
not
must say we are a largest group of.
Hello.
We should together should try to because these webinars are basically meant to envision ourselves on what is the road ahead and how we can affect policy making in this country. You as the administrator in your state and we in other states can jointly with our this background knowledge can slowly as a group affect these decisions. But as I told you, if we start offering a healthcare delivery model or financing model to a category of people for which it is not meant, it will ultimately disturb the large long-term planning of the healthcare financing in this country and will be very injurious to those people who are in the service delivery area, because the money in the service delivery area, the money need, the finance needed in the service delivery will decrease and will not be very good.
Hello.
Okay.
So by this time, sir, yes, sir. Yes, sir. Please go ahead, sir. We have not seen your raised hand, so there is some confusion. Yes, sir. Please go ahead.
Dr. Gupta Saabji, I am a MBBS and MD hospital administrator. I have done MBA, 3 MBAs, and all you have done since 80s. I am listening all the lecture throughout India. But what is the problem with
Sir,
the budget is a GP,
sorry.
healthcare is a less. For our fault,
Sir,
we
sorry
are not
interrupting
convincing the
sir,
politicians.
interrupting you. Sir, sorry, I'm interrupting you, sir. This is not the topic of the decision, sir. I think we have the other questions also pending, sir. Thank you.
Okay, okay. Thank you very much. We'll see later. Okay.
So, sir, till now there is no raised hand I am seeing as of now. But, sir, there is one question in my mind, sir. Because sir, we are always talking about the strategies to healthcare deliveries. So, sir, can we have any cost containment strategies so that, sir, we can properly utilize our funding, especially the healthcare funding?
Okay.
Please, sir.
Cost containment strategy, two strategies I told you just now. One is for the hospital care. I said take people out of the hospital and provide the care at their homes or outside the hospital boundary. I'm talking about economy of scale coming to super specialty and specialty hospital by producing, concentrating the resources at one place and creating economy of scale and providing the services at a cheaper, we can produce services at a cheaper cost. Then I told you that we should also try to have network hospitals where we can send our patients, not create a service everywhere that is not required. Then I told you that the post-hospitalization, the primary and pre-hospitalization care, I told you we can, a lot of things, we can have the clinics there, we can have retail pharmacies there, we can have telehealth services, digital health we can provide, and especially post-hospitalization care. That is one area we can have home health care. Home health care, a model we can develop where the patient can be provided and we can have remote monitoring of that patient rather than patient coming in person. Cost containment will be there. We can delegate rehab to not the hospital care, but to the post-discharge care. We can put the long-term care, we say rehab care, we say we can provide at the periphery. And at the very basic level, even below the health wellness center, because health wellness center is the contact point where the CHO and ANMs are in contact with these people. Below that, we can work on self-care models. Self-care models are those models which are below health. Nobody is intervening then. So our healthcare needs, healthcare seekers will decrease. So we can look at fitness and wellness. We can look at health wellness monitoring by the person himself. Now the mobile phones have got all those apps which you can monitor. We can look at mental health. We can look at yoga. We can look at nutrition. We can look at health screening and testing being held in their area. So NCDs, as I told you, is the changing part, disruptive actions happening in the health economy. We can look at that. So these all things will bring down the healthcare funding needs, and more importantly, utilizing your existing resource person. What has happened from 2013, if you see broadly in this country, we have not created a new infrastructure largely at the country's level, national level or state level for NQAS. We have utilized our existing infrastructure only to create these positions with some additions and started to bring quality. The similar model we have now put to health wellness centers, where underutilized sub-centers have been converted to health wellness center, and then utilizing the services of the CHO, and same staff, same people are now delivering more care. So these are the cost containment strategies we can always put at the basic level in this healthcare system.
Thank you, sir. I think Major Guru Prasad has raised his hand. So over to you.
Yes.
Sir, immensely grateful to you for this very, very wonderful presentation. Thank you so much for that. Just had one question. It was just crossing my mind. Would you have any kind of statistics or insights on what is the kind of catastrophic health spending that we have here in India? Any just views on that, sir? Because that was one thing which I wanted to understand.
Okay. Catastrophic healthcare spending, we don't have any data which is produced by our system. But of course, broadly speaking, when we are talking of out-of-pocket expenditure being conducted by the people, normally people shun away from spending money. We have seen in our healthcare setting also, when the people come with severe ailment to, and the budget of healthcare is too much for that ailment, sometimes people just give in and go away from the healthcare center for some local remedy and vanish away. So, but on the contrary, there are people who have gone into that spending in their ailment, and the end result is not good, and they have ended up selling their assets or going into high debt. But there is no actual data which I can trace. I am not aware of it. The system which is there, I think it is good to, if we create, somebody create. Do you have any data on that? Do you have any data on that?
Right, sir. Thank you, sir. Thank you so much.
Okay. Okay.
So any other questions coming from the audiences?
Sir, may I?
Yeah, please. Please go ahead.
Sir,
Introduce yourself.
in the line of our earlier colleague, sir, is there any state-wise comparative data or model is there? Is in India particularly health is a state subject, so the
Yes,
health
it is.
expenditure of
It is there. The same doctor showing you, I will share here on with the academy. They can share with you the national health profile, or you can download it. It got state-wise
Yes, sir.
data also.
Yes, sir. Yes, sir.
It has got state-wise data also for all states. So you can look at this thing. It has got a lot of data. You can see India, Jammu Kashmir, Himachal. It is showing state-wise data. Yes.
Okay.
It's showing Haryana, Punjab and cities. It is showing data. A lot of data is available in National Health Profile. You can see Maharashtra, Gujarat. This is all breakup, and we can have all funding, spending have been there. You can look at the major states. What is their mortality, their financial data? They are all available in this National Health Profile.
Yes.
Sir, can I open to one discussion, sir? It's just coming in my mind, sir.
Yes.
Because
Yes.
sir, you are also an MBA assessor, sir, and sir, the accreditation, sir, generally it will lead to a kind of cost increasing cost, at least for a time being, sir. Its initial investment is more, and sir, then sir, we have the very poor people in our country. Sir, can it be possible those poor people can get the treatment from these accreditation hospitals, those who are from the private sector, sir? And what can be the strategy as a whole we can implement so that the more are the beneficiaries with this outcome, sir?
Okay. So you have seen it already. I think we always talk about differential pricing concept in healthcare. With differential pricing is a model which is available to have private healthcare industry for NABH accredited hospital. It is there. So I told two things. Government as a regulator can control prices. Government as a regulator can control prices to some extent. So the government, if exercises the price control on, say, a 15% of the beds available in a hospital or a service available in a hospital has to be delivered at this much of price. So these people can always be included in that. So the poor who can buy this service from a very good hospital, quality accredited hospital, and hospital will also not shun away from this responsibility because it's a social good as well. And under CSR or other facilities, they can also rope in the funds to do this. I think, yes, differential pricing is the only strategy which can be used there to do that.
Thank you, sir. Sir, more questions are coming. Please go ahead. Suhail? Suhail, you're online?
So thank you. It was there by previously. Sorry.
Okay.
So, sir, I think, sir, no more questions from the participants coming, sir. And our clock is also ticking towards the conclusion of the session. With your permission, can we go for it, sir?
Yes, yes, yes.
Yeah.
I
So,
think
sir,
we got. Let me see. We have got Major General Vikas Singh ji here.
sir,
Let him.
please.
Somebody from the board must come here to. And then, can I call Major General Vikas ji to be here if he's there?
So, please, sir.
Let me see in
Yeah.
the list.
Ashish, I'm here.
Okay, sir. Please try to conclude this, sir.
First of all, my heartiest congratulations to you for such a wonderful session, and no surprise at all coming from you. So it was a very kind of a comprehensive presentation. I'm sure many would have benefited, especially the younger hospital administrators. I could see some remarks coming from Manipal Hospital that the residents have really benefited from you, and you have covered their syllabus for paper 2 to a large extent. So wonderful, Ashish. Thank you so much for taking your time out. I know you are a very busy person, but you have taken your time out to address all of us and conduct this webinar. Most beautifully done. And my second point to all the people who are here is that we would also be covering this, aspect or taking it further during our upcoming conference, which has got the theme of building resilient healthcare organizations for tomorrow. And in fact, Dr. Ashish's, this webinar was a well thought of, strategy as a build up towards that end. It's a very important topic, healthcare financing, and for the resilience of our organizations in the future also. So we'll have more of this also in the conference. I would encourage all of you to do register for this SASH 2023. Dr. Ashish has been a pioneer in this direction. He held the first SASH 2023 way back in 2013. Ashish, was it?
Yes, sir.
Yeah, so this is his efforts in that direction which are continuing. So it will be great to have many of you join in for this conference. So I would thank all the participants also for taking their time out and being here with us. This is something which we do take very seriously, these webinars, and we do try to give a lot of value to them, and bring speakers and experts in their field to these webinars. So thank you so much, Ashish. Thank you, Sumit, also for doing a great job as a moderator, and
Thank you.
on behalf of the AHA. Right? God
Thank
bless
you
you
very much,
all,
sir.
and take care. Thank you.
Thank you, sir. Good day, sir.
Good night.
So by this, we are actually closing our session. And thank you, Ashish sir, for all the valuable information that you have given us. And I'm very sure all are getting a lot of, sir, the kind of thoughts are provoking their mind. And also I'm thanking to all the AHS support staff who have made this happen. Also all the audiences who have patience in listening. And of course, they all follow our directions and it goes very smoothly. Thank you very much, sir, once again. Thank you to everyone. Over to you, sir.
Thank you, sir.